Good morning, everyone, or good afternoon, wherever you might be. My name is Virgil Simons. I'm the founder and president of the Prostate Net, and I'm going to be your moderator in today's session. And I welcome you to the continuing town hall series by the Mayo Clinic. Today, we're going to be talking about prostate cancer. We have many things to talk about that hopefully will provide information and education to you, but I wanted to emphasize one thing of importance. This is your meeting, not our meeting. This is for you to be able to learn a little bit and talk a lot if you want. We want to have all of your questions answered, all of your concerns addressed, and all the hope that you need to be able to deal with this disease reemerging in yourselves and in your family and your community. So we're going to start off today with a little bit of housekeeping to be able to help you understand what we're going to be doing today. We have a great group of panelists that we'll talk about in just a minute, but basically be certain that your computers or phones are on mute. If you want to have questions, use the chat feature to type it in, or either to use the Q&A feature to ask the questions, and hopefully I'll see them, and we'll get them answered by one of our panel members so that you'll be able to understand and know, all that you need to know about it. Um, we're going to be recording the session, and you'll be able to see it later on in case you missed parts of it as we go. You want to go back and just refresh something you didn't catch the first time around. So again, we talked about our panel. We have a great group of panelists here. Uh, Joining me, first off, is Dr. Roxana Dronka. She is an associate professor of oncology and also the chair of the Mayo Clinic Division of Hematology and Oncology. She's also a outstanding researcher in the field of tumor immunology, unitary malignancies, and malignant melanoma. Her goal is really to understand the interaction between the immune system and cancer, to study the dynamics and mechanisms of systemic immune regulation for patients with advanced malignancies and develop innovative approaches to cancer therapies that utilize chemotherapy and immunotherapy agents on an individualized fashion. Dr. Dronka has received federal funding to support her research in identifying biomarkers of response to these novel immune checkpoint inhibitors. And in collaboration with Dr. Haidong Dong, she serves as the interim deputy director of the Mayo Clinic Comprehensive Cancer Center in Florida and is an active member of the Florida Executive Operations Team. I think, we look at, her role here today is to help us understand what's happening in the clinic as we're being treated or diagnosed in some cases for the disease or the progression of the disease. So when you think of the kind of questions that she can answer for you is what kind of medications are out there available? How do they work? How do they last? What are the progression concerns area for the disease? What things that are happening in the future or in the near present that are going to be important for us as patients and community members to be able to understand and address the diseases. So again, on the panel, we have Dr. Falakini Odedna, who is the Associate Director for the Center of Health Equity and Community Engagement Research at Mayo. She's also the Director of the Community Health Equity and Research Center in Florida and Director of the Center's Global Health Equity Initiatives, all for Mayo Clinic. She's also a principal investigator and founding program director of the National Cancer Institute's EGRP, which is supported by the Prostate Cancer Transatlantic Consortium, in that she's looking to try to find those things of commonality in prostate cancer in the United States, in the Caribbean, and in Africa. Those things that can be acted upon to help us understand better what the disease is, the genetic makeup of it, why African American or men of African descent have greater incidence of mortality. To be able to understand that, for almost 30 years now, our research, education, training, community outreach activities have exclusively focused on addressing these health inequities across the board and in terms of finding programs to really get the message out into the community on a global basis. She's been funded primarily by the National Institutes of Health, the National Cancer Institute, and Department of Defense Prostate Cancer Research Program, focusing on those predictors of cancer health disparities and cost-effective community-based behavioral interventions to improve the health of minority populations, particularly Black men globally. In 2005, our research program evolved into a global program that includes increased participation of people in African descent in clinical trials. And then through the NIH National Cancer Center Awards, our research program has implemented community research registries for Black and Latino populations, community education programs on clinical trials research, training webinars, and scientific conferences focused on clinical trials, including the Biennial Global Cancer Conference on Oncology, Clinical Trials in Blacks. She's currently the site and coordinating PI for Global Prostate Cancer Research Program, the Ironman study, which focuses on identifying advanced prostate cancer in men throughout the world. And based upon her work in this area, she has led a variety of clinical trials. She was awarded the Living Legend Award for her innovations in health and economic impact during the first All Africa Clinical Trial Summit in 2017. And she is personally and professionally committed to eliminating cancer disparities, especially in people of African descent. She and I have worked together for a couple of decades now that I think about it. And it's a pleasure to see her because she is incredibly knowledgeable, but apart from that, she's incredibly committed to being in partnership with patients to help achieve the research agendas that she draws. This hardly lasts, I guess I'm last, as it should be. One of the other survivors that we have with us is Mr. Arnold A.J. Merriweather from Jacksonville, Florida. You know, AJ is a retired postal employee. He's had both prostate and lung cancer, which should qualify as to be a double survivor of some kind. But again, he has taken that bit of a lemon and turned it into lemonade, and that he has made the issue of surviving cancer one that is part of his everyday life. He lives to speak and communicate and motivate and enjoying communities to become part of the process of, first of all, facing and understanding the risk that we face from cancers, and also being able to take the power that is present in our communities to be able to turn it to our advantages, to be able to make it work for us. You know, he's also a military veteran. He has used that as a pulpit to be able to talk statewide to various other veterans and the veteran organizations. He's been able to talk about the issue of advocacy, of being able to take the experiences as a patient, turn it into survivorship for people, you know, out there who are facing the same things that he's faced. He's also a great speaker. He is a foot soldier in the war against prostate cancer and the affected one. He's not alone in this journey because his wife is also very active. She's a member of the Phi Delta Kappa educator sorority, and she's enlisted his support. I think she should have said we've drafted his support to be part of it. But she is also very, very committed in the whole area of cancer inequities. A quiet voice, but a very, very effective voice. Seeing her, she doesn't say much, and that's probably because AJ speaks a lot, but she does speak with authority, and she speaks with confidence, and she speaks with sincerity, being able to talk about things that are important to her community. So I think we started looking at, you know, the two of them, you know, they are the embodiment of what we want to be able to talk about in terms of patient centricity and patient engagement, of being able to broaden the information base in the inner cities and in minority communities across the country, and create an inclusive network that has a broader outreach for both men and the women in their lives, that are able to start talking about, you know, the fact that cancer is not just a male disease, it's a family disease, because everybody in the family has cancer when the guy has cancer. And I think the key that we have to look at in terms of beating the disease is to involve our families, our friends, our neighbors, our communities in being able to address it. And last is myself. As I mentioned, I am founder and president of the Prostate Net, which is a nonprofit education advocacy organization. We operate globally. I'm based in Barcelona, Spain, but we work in the United States, in Australia, in India, in Europe, and in Africa to try to provide credible and actionable information that will help minimize the negative impact of prostate cancer really around the world. I'm a 26-year survivor of prostate cancer and basically became an advocate 1 year after the surgery and have really kept going from there. I'm a member of the American Association for Cancer Research, the American Society of Clinical Oncology, the European Association of Urology and Minorities in Cancer Research. I am the chair emeritus of the congressionally directed medical research program for prostate cancer, which I continue to serve for 16 years now. I'm also a member of the National Cancer Institute's Board of Scientific Counselors, and served at various committees and external advisory boards for institutions in the United States and in Europe. My whole goal is really to just reemphasize the message that as patients, we have a central role in everything that has to do with prostate. Without patients, clinical facilities can exist. Without patients, research can't be done. And without patients, we can't change the future in terms of the paradigm of this disease. So AJ and I are here to represent all of you and all of those who are patients and families of patients to emphasize that yours is an integral part of what we're going to be doing. So having said that, there's one last little bit here of housekeeping. As I mentioned, we are going to entertain the questions. There'll be questions will be answered at the end of each presentation. And at the end of the overall event, we will have the opportunity and request that you participate in a survey that will tell us, how well we did or how well we didn't do and the things we need to do to improve. So starting with that, opening remarks, I want to introduce the first topic, which is going to be the early detection screening for prostate cancer, the realities and the myths associated behind that. And I'm going to start off with my friend AJ, just to talk about it from the patient perspective. What does early detection and screening mean for you?
Thank you, Virgil. Early detection to me is identifying the symptoms. A good example I will share with you is a nephew this week. I had a nephew come over and visit with me, and this should go to all men. He came over, Virgil, and I promise you, he stayed 2 hours. He ran to the bathroom every 15 minutes. And I sat there in the patio talking to him, and I was just watching him. And I said, nephew, what's wrong? He said, I keep going to the bathroom. And he's a postal worker himself. And he said, I can't do my job at night because I keep running to the bathroom. And I sat there, Virgil, and I said to myself, this is not normal. He said, well, I've been doing that for about a year. And I said to him, I say, you need to call your urologist, your primary. So I went and got my little book with all the early signs. And I said, well, I'm gonna just tell you, here's what it says, early detection. And out of those markers, he had maybe 4 markers that concerns me. And this is why it's so important to men to understand what is the warning sign. One, he ran to the bathroom. He said, well, I drank a lot of water last night and I go to the bathroom through the day. I said, no. I say, I know the symptoms. So he said, I go to the bathroom and I stand up and I wait. And I say, well, that's that slow motion, that stop and go. And one of the things I said to him was, I'm a survivor. I know the signs. And you should know from my experience that I done lived that journey. So one of the things he said was my back be hurting. I call that from loading the mail trucks. I said, no, those are early signs. And I just watched him, Virgil, for about the first hour, Virgil. He would go to the bathroom, sit down, and he'd say, wait a minute, I got to go back to the bathroom. And he did that, and it scared me because it wasn't nothing that was happening just this month. He said it's been happening for months, ever since he came back from Iraq. And I basically told him, I said, you know, we got a family history. You got your three uncles, two had prostate cancer, one had enlarged prostate. And what I was sharing with him was the history of this disease, that it could skip generations, it could be in one generation, but it's in our DNA. So to answer your question, it's so important that even as an advocate, we recognize when people around us having issues that don't know the symptom, that we take that time and stop what we're doing and educate them right then and get them the resources. And I thank Dr. O for bringing me in about 8 years ago in her team. And through those journeys, being with Dr. Odette, and I have networked with other organizations such as yourself, UF, Mayo, the Proton Center, Dr. Mendenhall. And one of the things we want to encourage men, and by closing by saying this, as an advocate and a survivor, we are our brother's keeper. We must recognize that some men don't know the signs, some men won't go to the doctor. And even the next day, Virgil, I was calling him on the phone. Did you call the urologist? I gave him my urologist. I say call, because he was so adamant about the number one. He said, I'm not very romantic in my relationship with my spouse. I say, those are signs that you really need to take serious. And if you done had this so many months, it scared me, because we know early detection saves lives. And if we don't do it early, but we just overlook the symptom, I'm drinking a lot of water. That was the craziest thing I heard, because water ain't gonna make you do that. So that was my opening on that, Mr. Virgin.
Well, you know, the whole thing with that is that we always make up our own reality when we don't want to really deal with the facts. So for him, you know, the quick solution was, oh, I've been drinking too much water. And that, you know, obviated him saying that I got a problem. So I think, you know, the whole thing is that we got to be able to face the fact that the problems exist and deal with them. I think I kind of like to go now and talk with Dr. Dronka in terms of, you know, the clinical issues of early detection and screening. You know, there's been a lot that is said both positively and negatively. When we look at the PSA test, for example, there's been a great deal of controversy over the USPSTF's rating of that. And we look at what's happened in Europe based on the research that they've done that have shown, you know, positive benefit in doing screening. So I think, you know, let's talk a little about the whole mechanism of PSA detection, early detection and screening.
Thank you. And Mr. Meriwether, thank you so much for that opening. I think there were so many lessons in there for me as well as physician. I think, you know, one thing that I took away is that the fact that as physicians, we really need to encourage our patients to discuss about this. We need to seek the answer if patients have symptoms. Sometimes it's not something that patients will easily disclose, you know, to a physician that they may be seeing, you know, once a year. They may disclose to family members, but sometimes not as easily to doctors. So I think we really need to really target these questions and seek answers to them. You said another important thing, that we need to understand the patient's family history. We know that someone who's had a family history, we really need to start talking about all of this early on, you know, potentially in their 40s, not wait until, you know, mid 50s or 50s. So it makes a huge difference knowing everything about our patient and understanding their symptoms, their values, their family history. So I think this was a very important, you know, lesson there for me. Yes, we do, to go to the PSA screening, we do know that early detection saves lives, and we need to screen a number of patients to save one life, but that's one life saved. And, you know, the screening nowadays is mainly focused on PSA, which is a blood test. So it is not as, you know, difficult, I would say, as, you know, in the past, you know, all the other physical exam type of detection. We do know that once you screen or once you get a PSA, especially if you have a value that is borderline or potentially abnormal, that you need to refer the patient for urological evaluation. So as physicians, we need to collaborate with each other. We need to know when to send the patient. A lot of times we'll repeat another PSA in a few weeks to make sure or evaluate for other factors that could potentially transiently increase the PSA. Let's say antibiotic treatment if we suspect an infection, or for a transient elevation, we may repeat in a few weeks. But if the value is high, in general, we would refer patients to urology. They may do other specialized tests like looking at the free PSA percentage in blood and then proceed with, either an MRI or an ultrasound. And ultimately, the diagnosis of prostate cancer is made by biopsy. But there are a lot of different points, through that journey that I think is important to be partnering with the patients so they understand exactly what are the risks, what are the benefits of screening, what does it mean if you detect early. And I truly think that this should be a shared decision making, and this should be an informed decision from a patient side. But that means we need to talk about it. We need to talk about it openly. We need to be able to present, both sides of the story, and then let our patients decide and make up their minds. And sometimes, in my experience, it takes more than one time. It takes a continued conversation for somebody to truly decide, what they want to do. There are a lot of decision aids, for instance, to the American Cancer Society. They have wonderful patient education materials that I've been using in my practice as well. And I think all of this discussion is hugely important.
It was a great answer, Doctor. But I think one of the things that you touched on are two things. First off, that multiple times coming back to get the information. We find that oftentimes we encourage the patient to go with someone, their spouse, their friend, somebody, because invariably the person who's coming along hears things differently than what the patient is hearing. And the thing is that, you go out and say to the patient, well, the doctor said, you didn't say that. I said, yeah, he did say that. I heard him. So it's important that we have somebody in the room with us to be able to say, all right, I'm an independent listener and maybe even an independent questioner. So that's important. Now, the other thing that's going to be important when we start talking about the issue of risk, we know that men of African descent have higher incidence of prostate cancer, higher mortality of prostate cancer. Is this a Black thing? What is it about us that predisposes us toward this?
I think, you raised a very important research question. I do think, and indeed, studies show that African American patients do have a potentially more aggressive course, an earlier, age of onset of prostate cancer, maybe more family history. And there are a lot of studies trying to understand exactly why. We're going to talk about a study that Mayo Clinic is doing in a little bit, looking at the various aspects of potential interaction with the immune system, the genetic makeup. We're doing a lot of genetic testing in patients who are newly diagnosed with prostate cancer to detect genes that potentially can confer a susceptibility to developing cancer. So we do know that the phenotype, we call it, could potentially be different, but we also know from various studies that actually African American patients respond just as well, if not better, to treatments for localized disease, to radiation, to surgery, or to treatments in the advanced stage or metastatic cancer, like their Caucasian or Asian, counterparts. So while they could potentially present, more aggressively and at a younger age, they respond very well to treatment. So again, the issue of an early detection, early diagnosis becomes paramount.
I think it's key when you mention that, because the qualifying statement is they respond as well if they are diagnosed and treated at the same time as the white counterparts. Unfortunately, that's not what's happening in many cases. And I think with that, I want to talk with Dr. Odedna, because again, her research is dealing with how do we meet those men who are not getting, the best of care at the time they should get it, and becoming, statistics in terms of the disparities.
Yeah, absolutely. So first of all, I want to say it is just a pleasure to be on a panel with distinguished survivors like yourself, Mr. Simmons, as well as Mr. Merriweather. I think, I've been in research for about 30 years now, and my research has been made better by having partners like you, decades of work that just standing side by side with both of you and other survivors to really, really understand this disease. For those who know me pre the COVID-19, when we celebrate the Prostate Cancer Awareness Month, the very first thing that I asked our participants is the question, how many of you, if you could just do this, personally, as you're watching us over the webinar as well as Facebook, how many of you within the last 6 months have really changed the engine of your car? Or tune up your car or your bike? How many of you, if you can raise up your hand? And then put down your hand. And then I will ask the questions. How many of you within that last 6 months or 1 year, if you are 40 years or older, have checked your own engine? Go to a doctor and try to just sort of do prostate health, which is exactly what Mr. Merriweather said in his opening. And it is truly a sad statistics. And there are multiple reasons, as Mr. Simmons shared, that we do have the statistics with Black men who really have the highest incidence, the highest mortality. And it does not matter whether you're a Black man in the United States, or you're a Black man in Africa, or you're a Black man in the Caribbean, or you're a Black man in Europe. The same thing happens. So there are 3 things that we have found through research that really contribute to this. One is healthcare system. We know that the more access that you have and the more ability that you're really able to get access for healthcare, the more likely that you are more able to get early diagnosis and go for the care. The provider as well, and Dr. Dronka speaks very well about it, about the responsibility of providers. It is alarming to me, some of the studies that we have done with men who are between the age of 40 and 60. And they said that they have seen a provider within the last year, but the provider has not talked to them about the risk of prostate cancer in Black men, and they are Black men. And more saddened is the fact that majority of them said, even when they talk to me and they ask me to do PSA, the blood test, they do not even talk to me about maybe doing digital rectal exam. And we know that doing both really increases the chances of really doing early detection. So that is the provider level. So remember, I've talked about the healthcare system level because of the fact that you have to have that access, and then the provider level. But I want to end with the individual level and the responsibility that we have as Black communities, as Black men, as loved ones of Black men. There are certain things that really impact us that we have found within almost over 25 years of way that we are studying this. The fact that if you are able to do your annual physical regularly, the screening will be included in it. There's also this digital rectal exam myth, in which we really don't want anyone putting their hands we know where. And I see it across the nations that I go to, from Bahamas to Jamaica to Morocco to Nigeria to Ghana to United States. It is really alarming how I see where Black men are really not comfortable with digital rectal exam and have assigned so many things to it. We need to break this myth. It is very important. There are other things like procrastination. Mr. Merriweather talks about this. Symptom interpretation. When we get the symptoms, we are oftentimes saying it's something else. There are other things like we don't seek information to really be able to understand what is going on. We don't know a family history of cancer. Mr. Merriweather talked about the family history of cancer. And if you don't know it, you don't know that you're much more susceptible. There is the issue of knowledge. There is the issue of awareness. There's the issue of comprehension, health literacy, so many issues. But I'm going to end with the issue of PSA controversy. I am going to tell you, and this is, I feel very comfortable sharing this, the controversy that surrounds PSA has really harmed our community. And it has harmed our community in multiple ways. This is because majority of the studies that are done in the United States does not include a lot of Black men. Mr. Simmons mentioned the fact that the European study, which actually had more Black men involved, actually showed that PSA had some, really advantages of doing this. But we have done studies in the United States that does not include all of us. And, talking about participating in clinical trials, we'll pack that on the side, and I hope it will come up in the conversation. But we are being given recommendations that really are not personalized to our community, that are not personalized to being Black. And therefore, we really need to talk to our physician. I'm going to tell you, when my husband turned 40, I went with him to his annual physical. And it was interesting because I kept quiet. And at the end, she never mentioned once about the idea that the Black men are at risk, and she is an internist. And I had to tell her that you haven't shared with him that he has a risk for prostate cancer and should be considering that, giving him the pros and cons. And I had to say, well, share with him the pros and cons. And I'm making an informed decision for him to actually get his baseline for PSA right now, so that if it increases, we can catch it early. I also want you to do digital rectal exam. My husband didn't like it, but I liked it. I was informed. I didn't want him. So we really need to continue to talk to each other about the science behind the screening, the science behind the recommendations, and make sure that we're doing what is best for our community.
I totally agree with it, Vlaki, because it is important. I think I'm a prime example because I didn't have a clue in terms of PSA. I didn't have a clue about prostate cancer. I just heard prostate cancer is an old man's disease, and again, thinking about procrastination, I just totally resisted it. And I had a friend who came to me and she said, you ever had a PSA test? I said, no, it's an old man's disease. It's, why should you? She said, well, it's important. You do it. I said, why? She said, well, because the highest incidence rates are among Black men and Vietnam veterans. And guess what, asshole, you're both. So it was a case. I said, all right. So it was a situation where I resisted the whole idea. And but I said, look, I've got a physical coming up. When I go, and I'll get it then. So again, I went to the doctor, and it was a doctor, Park Avenue, New York City doctors on the staff of Columbia Medical School and all that. And I said, hey, doc, finish talking about this PSA test. He said, don't worry about it. We'll take it another couple of years, and then, we'll deal with it then. I said, look, I'm hearing things about, I'm at risk. You're gonna have the needle in my arm anyways, just put another vial and take the blood. And up jumped the devil. So that was the first indication of, prostate cancer for me. And I think, it's a message that says, we can't be so blasé about it. And we can't assume that, we're all out here fat, dumb, and happy, and it's not gonna touch us. And I think what I wanna do with that is kind of go then to talk back with Dr. Dronka. We'll start looking at the idea of diagnosis and managing treatment. You said very clearly that forget about the PSA, it's an indicator, but only a biopsy can actually determine whether you have prostate cancer or not. So let's do a couple of things. Let's talk about, what are some of the things that could cause us to have a high PSA? And then after we have the biopsy, what does that really tell us?
So, I think this is a very important question. Can anything else, increase the PSA, or is all prostate cancer? And we know that PSA can be high and a person, may not have prostate cancer. We also know that the PSA can be low and the person can have prostate cancer. So it is an indicator, an imperfect indicator, but at least is a starting point. And Dr. Odedina talked about the digital rectal examination to truly add yet more, I think to the clinical picture and really inform our decision making. Other causes of increased PSA, one may have enlarged prostate. Mr. Meriwether, talked about his nephew and symptoms. Those could also be the symptoms of an enlarged prostate or BPH that can increase your PSA as well. And as I mentioned, certain tests that then kind of piggyback on that, the percentage of free PSA or, other specialized tests can at least give us a little bit of an indication. Is this BPH, where there is more free PSA, or potentially cancer where there is less free PSA in the blood? and make a decision to proceed with further testing then. If one has an infection like prostatitis or even a urinary tract infection, that can transiently increase the PSA. So I think if somebody has symptoms that could potentially lead us to think that this is an infection, pain, potential fever, then usually the physicians would prescribe a course of antibiotics and recheck the PSA after that. Other potentially, sexual activity can transiently increase this. They usually say is not all that much of an increase for instance, baseline screening to influence the baseline screening. But if you're doing a repeat screening to check on a borderline value, we often would recommend that men abstain from that for a day or two just to get a more precise, value. Some have even, said that physical activity such as riding a bicycle, etc., could potentially transiently elevate PSA. But we're talking about less, less of an absolute increase than, for instance, with an infection or with a BPH, which is kind of where I think our diagnostic dilemma is mainly. In general, urologists will proceed with a digital rectal examination that can diagnose abnormalities in the posterior part of the prostate, the lateral part of the prostate. Definitely, if that is abnormal, then biopsy is the next step. And sometimes they will do an ultrasound to look at what we call PSA density. So what's the proportion between the PSA value and the gland volume, and that can also tell us a little bit if this is BPH versus prostate cancer. So these are all tools to help us determine how much of a need we have right now for a biopsy. And if we potentially suspect, strongly suspect prostate cancer, we usually recommend a biopsy immediately. Some, decide to wait and repeat some tests in a few weeks, but the key thing here with waiting is watchful waiting. So you're not waiting and going away and coming back 5 years later. It's a watchful waiting, and the physician, I think, is also responsible to make sure that the patient comes back and follows up if we decide to take this approach.
I think it's also important to know that that all biopsies are not the same. The number of cores that are taken in the biopsy is important. We recommend that at least 12 cores are going to be taken. And then cores, basically, you're taking a punch and you're punching some tissue out of the prostate gland, and then the pathologist is analyzing it. So I think the thing we need to talk about is understanding that pathology report, because in many cases, the guy goes back to the doctor and says, well, you got prostate cancer, and that's the end of the discussion. The question is that, what is the grade of my prostate cancer? What is the risk? How many cores did you find cancer in? What's the overall cancer volume? So these are all questions that are going to help determine whether you're going to be treated immediately or not.
Exactly. That's not the end of the conversation, it's the beginning of a very long conversation. And a lot of things that we need to look at. As you mentioned, that usually a good biopsy does have, at least 12 cores, and then the pathologist will look exactly at how many cores are involved, what percentage of that core is involved, and then they give us a very important index, which is, we call it the Gleason score. And basically, the Gleason score is looking at the prostate cancers under the microscope and seeing how do they look compared to the normal prostate tissue. The more alike it looks to the normal prostate tissue, the lower the number and the less aggressive the cancer, because it's almost like the normal prostate. The more undifferentiated, or you can't really tell, what cell this came, from. It doesn't look like prostate cancer. It doesn't look like stomach cancer. It doesn't look like almost anything, just a very young cell. That's a very undifferentiated prostate cancer and will get a higher number. So the numbers go from 1 to 5 to really classify this very well differentiated 1, well differentiated 2, kind of a moderate 3, somewhat undifferentiated 4, and poorly differentiated or undifferentiated is 5. And we look at each core, we look at 2 patterns. What's the most predominant pattern? So what's 50% of more of that core, what grade is that, or what number is that? Is it 5, is it 4, is it 3? So we assign a number to the most prominent pattern, and then we assign a second number to the pattern that comes right next to it. So what's the second more prominent part of that core looking like? So the Gleason score is not just one number, it's a sum of numbers, and they are important to say Gleason 7, or we say Gleason 3 plus 4 equals 7. And it's very important for us to know, I gave the example of 3 plus 4, which is probably the most important. 3 plus 4 is not the same as 4 plus 3.
Right.
3 plus 4 means that most of that core looks well differentiated, with some part of a more undifferentiated. 4 plus 3 means that most of that core is undifferentiated, with some parts that look better. So you have looks better with some parts that will look worse, with looks bad with some parts that look, better. So for us, it's a very important, determination. So we start with that. We start with the Gleason, with the patterns, with how much is involved, what is the PSA at diagnosis, and we make up we call it a risk score, where we kind of look at what is the risk of progression of this cancer and what are the treatments that we should do or we should discuss with the patient. Is the prostate cancer really, really slow growing, a 3 plus 3 just in one core, 10% of one core, and really, if the patient doesn't want to have treatment right away, we have the time to really observe this closely? Or is this something that we need to intervene right away to give the person the best chance at a curative intent treatment?
AJ, from your standpoint, I mean, how did you manage the pathology report in terms of helping making your decision about what you're going to do for treatment?
One of the things, it took me years to understand what Doc just talked about. And that's one of the problems. I was sitting here listening to her, and I got to be honest with you. It took a lot of years and a lot of workshops and a lot of Dr. Odetna talking to people, and I'm listening. And Virgil, from us being in Amelia Island, the thing is, normal guys like me, Doc, I'm gonna be honest with you. Everything you said, it took years for me to process and understand. But put yourself in my shoes. I come to see you, and you say just what you just said to the audience. Go back on Virgil. We got to take somebody else with us to translate. And I was sitting here and I was saying, my experience, it took so long to understand the Gleason score. And when Virgil, you was talking about the cores, we take 12 samples. But one of the things I used to ask the doctor is, you take 12 biopsies or 12 samples out of the prostate, but you didn't say what I wanted to hear. And that is, in between those samples, can it be missed? You think about what I tell guys, you're gonna take 12 samples around the whole prostate. What happens in between that we don't test? In my mind, be like, okay, y'all went 12. In between that, it could be prostate cancer that you didn't hit. And when you was explaining it, I sat here and I was wishing that when we go to the doctor, I usually tell guys when I go with them, Doc, talk to us on our terms. Break it down in the layman's terms, because we get so confused with numbers and cores and all this. And I keep sitting up here wondering, is there a better way to communicate? It's two tiers. We got the professionals that understand what you're saying, and the next tier is the common person that's trying to understand what the professionals are saying. And in the middle, we all saying, what the hell did they say? So in my point is this, the answer you, Virgil, I apologize for rambling, but my point is this. It took a long time for me to understand everything, and basically just educating myself and listening to speakers and being invited to workshops. It took that many years, so many years for me to actually understand the terminology. And to this day, I still don't understand. When we said 3 plus 4 and 4 plus 3, and what my Gleason score is and what, you know, when you explain that to someone who just got diagnosed, I'm gonna be honest, doc,
Yeah.
they don't hear a word you say. And they'll look at me and say, can you interpret it? Man, all I can tell you is I don't understand it either. I've been at it for 11 years. But the point is, I wish that at some point when we talking to the patients and newly diagnosed, we understand what Virgil say. They don't hear us. And doc, your experience, Dr. Odetna, we all know men don't process things the same way women do. We don't always listen. And one of the problems we having right now is the example I gave with my nephew. He know the health problems I had. And it was just for the grace of God that God sent him over to the house, and for me to tell him, don't get scared, doc. Don't think it's prostate. It could be enlarged. I gave him material that I carry with me. I said, read this material, call your primary, tell them the symptoms. And it's just so hard with men. Men they just don't take this thing serious, Virgil. That's it.
And I think this is so important what you said. And I often tell my patients, I think this is a gap in a way, or you know, a shortcoming of the health system. You get an appointment with a doctor, right, of an hour. And what I'm doing there, I'm trying to teach you everything in an hour that I learned in medical school, residency and fellowship together. And here I am sitting and trying to, you know, give you all that information in an hour, expect that you are going to absorb it, when all you can think about is, oh my God, I just got this diagnosis. Oh my God, what does that mean for me, for my family, for my kids, for, you know, so it is a point very well taken. And throughout my career, I think this is the most important thing that I continue to try and adapt and adjust, you know, in speaking to patients and understanding how much of an information do I need to give right now, and how, and sometimes I do ask for 2 or 3 appointments, even though, you know, we talk about exactly the same thing. I don't think it's wasted time at all, because I think until the patient understands, exactly like you said, until you understand what is it and what are the options and what you need to do, until then there is an extra level of anxiety that will not let us make the right decision. Once you know what you're dealing with, it's a different conversation. And I see this over and over with my patients.
Well, I think it goes
If I
back
may
to,
add,
I'm gonna get just for a second, I'm gonna throw something in,
yeah.
Lucky, I'll give you my time, you can talk. There is a basic difference between men and women. When a woman enters into puberty, she automatically is ushered into the society of women. Her mothers, her aunts, her sisters, her girlfriends, everybody talks about health. They talk about, you know, you need to get, you know, mammogram, you need to get, you know, pap smears, you know, you need to get, you know, everything checked on a regular basis. And when something happens, she immediately goes to her girlfriends or someone close in the family, and they'll ask, well, what about this? And they'll immediately say, you know, you go to, you know, the doctor, you get this test or whatever. And so the support system is there. Whereas when a man enters into puberty and becomes a man, you know, there is that same support system that's out there. It's basically, as a man, you know, if I can get it up, I must be okay. And as long as we can get it up, we're okay. And we don't want to know about anything else. So, Falaki, I would address you from the standpoint of how are you addressing some of these cultural barriers that are part of our community?
Yeah, I mean, there's such, is so, what Mr. Merriweather said and what you just said is so loaded. And this is one of the reasons why it is so important that we need to be working with you to understand what the issues. I'll give an example. You know, one of the studies that we did in Florida was to really, you know, study thousands of prostate cancer survivors in Florida and talk to quite a number of them. And I'm going to tell you, they express exactly what Mr. Merriweather just expressed in what we call the point of prostate cancer diagnosis. That point of prostate cancer diagnosis is so crucial. And the men talked about the fact that once they hear you have prostate cancer, they are in shock, disbelief, fear, denial, overwhelmed. Why me? Looking at how is it going to impact my manhood? How will it affect my marriage? How, you know, how do I cope with this? In fact, one of the studies that we gave, one of the men said, how can a doctor tell me that and expect me to get into my car and drive safely back home? I'm in this mood that is not. And this is one of the reasons why at Mayo Clinic, we are trying to look at how can we support men, especially Black men, at the point of prostate cancer diagnosis. Dr. Dronka is right. Ideally, we will have the provider staying there and talking to you until you get it, until you feel better. But that's not the ideal solution. That is part of the problem with our healthcare system, not the physician. So what do we then do? For men who are just recently been diagnosed, to make sure that, number one, what Mr. Merriweather said, if you don't have somebody with you who is going to explain to you later on, who can hear what they're saying, how do we begin to support them at this point? And this is where we need to start using some of the things going into artificial intelligence that will be able to provide support at that point, because it's not going to be feasible for the physician to do that. We need to start relying, like prostate cancer survivors, like you, like Mr. Merriweather, that to say, you know what, if you want to give me a call, let's talk. I was in the bed, I've been through it, I can talk to you. In fact, at that point in time, one of the things that the majority of the men who participated in our study said is they would rather, at that point, when they were told that they have prostate cancer, talk to a survivor than continue talking to the patient, because they need to hear from somebody who looks like them and who is able to really take them through this experience. So we need so much. This is just not about the providers. We need the survivors to be able to. We might need to look into technology, into how do we do this at the point of entry. So a lot more research needed, a lot more that we need to do to be able to support the men. Yes, we want to do prevention, right? We want to do risk reduction. But the places that our men are really being affected is that from that point of prostate cancer diagnosis all the way through the survivorship phases, they do need support.
I think I want to kind of deviate a little bit here because we're getting some questions, and I think it's important that we answer them. Wendy Dean Golem was asking a little bit about, Mr. Merriweather's point in terms of addressing, the Black community. Also, Jordan Riddles, who is a Black urologic pathologist, who was talking about, the importance for him to be able to help make Black men understand the decisions that come out of pathology better. And also, the fact that Black men across the world have different outcomes than Caucasian people, and for a variety of reasons. So I think the thing is that we have here physicians asking, how can they can do a better job? What can they do in terms of being able to communicate with their communities of color that much better, that much easier? How do we address the issue? And I think I'll put it up to you, Falaki, as to address it initially, and we'll pull in Dr. Dronka as well.
Yes. So, I mean, this is really, and I want to mention, because you mentioned something in briefing that I want to emphasize. The tools that we currently have to diagnose, they are not perfect tools. And I think Dr. Dronka said that. But another issue that we have is that they have not been well tested in Black men and Black men globally. And so when we're looking at PSA, when you go to the Caribbean, when you go to Africa, how can we be having PSA in the thousands? What does it mean? What does it even mean, right? So Black men who are over there, and remember, some of those Black men who are in the Caribbean, Europe, or Africa, they are also in the United States as immigrants, right? There's no understanding of what is going on. And we are actually also seeing within group differences among Black men. So, while we are busy saying Black compared to white or Black compared to Latin, there is a real differences among the Black, which is saying that there has to be some epigenetics and environmental and genetic issues that we really need to better understand. Now, going back to how do we inform? I think that number one, what is very important is our partnership with survivors just like you. I do not make a move with outreach, with community engagement, without having key partners like yourself, because you truly understand what is needed and what we need to do. And what we are doing right now is one of the areas that we need to improve more, give this kind of sections and webinars. But in addition to that, we need to meet people where they are. You earlier on, Virgil, talked about being in barbershops. We do not expect that all the time the men are going to come to this webinar, right? But we need to ask ourselves, where are Black men? And how do we get to them where they are? And we are in this age that it is not about them coming to us, it's about us going to them. So we should show our face in that barbershop. We should show our face in that, fraternity. We should show our face with our veterans at the post. We should show our face in churches. Sometimes, yes, churches are very important. But what somebody just reminded me about a couple of weeks ago? A lot of our younger Black men are not going to church. So we really need to think about that. While we are saying we want to make, church is very key. But we need to ask ourselves, where are we going to meet them? At the basketball, game, wherever they are is where we need to meet them. And we need to make sure that when we provide the information that we are providing, they are information that are evidence-based information that are tailored to them. Don't bring information from other race and ethnicity that does not apply to them. We need to apply what is really focused on them. That really is going to be the information that they get. And we need to listen back to what they are saying. Because, we can easily throw our hands up and say, oh, they're not listening to us. No, they are listening. They are making decisions based on something. We really need to understand, why are they making those decisions? And how can we help them to be able to make better informed decisions?
I think the whole thing, there's a quotation that I use from Anais Nin in a lot of professional presentations I make around the world. And she had a very, very relevant quote that she says, "We don't see things as they are, we see them as we are." And too often, we're professionals and we think, oh, folks can see it the way we see it. Well, no, they don't. And that's part of the things that we have to deal with, we have to address. And I think, Dr. Dronka, I'm going to I'm going to click you in a second. I just had a question, but they just took it away from me. So anyway, I think what we'd like to do, Paul, if we can go to the commercials, the two videos now, it'd be a good time to play them, and we'll come back for more.
Hello, my name is Dr. Gerardo Colon Otero, and I am a medical oncologist at the Mayo Clinic. I'm here today to tell you about a new Mayo Clinic study. Prostate cancer is associated with worse outcomes in African American patients. We do not know why this is the case. I'm here to let you know about a Mayo Clinic study that is trying to find out why prostate cancer is more lethal in African American patients. We're evaluating the immune system in African American patients with prostate cancer and the effects of vitamin D deficiency on the immune system. Vitamin D deficiency is more common in African American patients and is associated with a higher mortality from multiple illnesses, including cancer. We do not know why vitamin D deficiency leads to higher cancer deaths, but we suspect that this may be related to the effects of vitamin D deficiency on the immune system. In this study, we will evaluate the immune function of the blood from 100 African American patients with localized prostate cancer and 100 African American patients with metastatic prostate cancer. The blood studies will be performed in the laboratory of Dr. Keith Knudson at the Mayo Clinic. We will measure vitamin D levels on these patients, and if low, we will replace it for 8 weeks and repeat the blood studies. Specifically, patients who agree to participate will have approximately 3 tablespoons of blood collected, and those with vitamin D deficiency will be provided free vitamin D replacement with repeat of the blood studies in 8 weeks. They will also be asked to complete a questionnaire on their quality of life before and after the 8 weeks of treatment. Patient will receive a gift card in appreciation for their participation. We hope that this study will result in important discoveries on why prostate cancer has a worse prognosis in African American patients, and that this study will lead to new treatments for this disease. I thank you for your attention.
Hi, I'm Dr. Folakemi Odedina, professor at Mayo Clinic, Florida, and the site director for the Center for Health Equity and Community Engagement Research. On average, about 30,000 Black men will hear the words "you have prostate cancer" in the US annually. The International Registry to Improve Outcomes in Men with Advanced Prostate Cancer, known as the Ironman Study, will study a minimum of 5,000 men with advanced prostate cancer across the world, including Black men in North America, Europe, Africa, and the Caribbean. The impact of this study is that it will help us to identify the treatment combinations that improve overall survival and patient-reported outcomes, such as general well-being, mental health, disease symptoms, safety, side effects, and quality of life. To be included in this registry study, individuals should be willing and able to provide written informed consent and authorization for personal health information. Males 21 years of age and above and diagnosed with prostate cancer. Patients will be enrolled in the study and followed for over 5 years. For more information about the Ironman study, contact the Mayo Clinic, Florida Center for Health Equity and Community Engagement Research. Thank you.
I think again, it was both important messages that came across. And I think one of the things that we really want to focus in on is at the end of the day, when we've come through all of this and we've been treated and we have our lives back, how do we survive? How do we move forward from there? And I think, AJ, obviously, you moved forward, then you had to move back again and had to move forward again. So what does survivorship mean for you?
Survivorship means to me is building bridges for the next person not to go through what me and you have went through. And it's basically sharing our experience. I want to piggyback on one thing. What can we do to encourage our men to be tested? And it's both to both doctors. I wish it was a way that we could have a patient advocate at every office. So when a person is first diagnosed and they come out that office all shocked, we got that shoulder. Hey, listen, man, you got a few seconds? Let me share with you what I went through as far as resources. One of the things Virgil said earlier, and I guess what it means to me is basically just building bridges, continuing to work the ground. I'm one of those ones, Dr. Odedin, I'm on the ground. I don't have a PhD, but I have a PhD in the streets. And that's being able to talk to a person level and telling them, if God can heal me, he can heal you, but you gotta do your homework. One of the problems we find with men, Virgil, is we just don't have that attention span. We just really, I'm listening to y'all and I'm trying to think of what can I say to give y'all practice something. And that is just having someone in that office that actually been through it, Doc, because when you are talking to that person multiple times, if they don't look like me and you, I'm gonna be honest with you, it's just gonna go through one ear and out the other one. But we gotta be able to find a different way, as Dr. Odedin say, to get the messages out there in the street. Because you can do social media, you can do we did the barbershop, we done the barbershop, did the barbershop, that's done. Now we're in the 21st century with COVID. COVID has restricted us from going out and doing health fairs, church and gathering. One of the things we are doing, Virgil, with the American Legion Post and Dr. Odedin, we are partnering. I found that partnering with Dr. Odedin, other health organizations, we are broadening our network because one shoe don't fit all. We gotta have part, as you told me in Amelia Island, Virgin, you say, we gotta have skin in the game in order to be a part of the game. Well, that articulates to what we are saying. In order to get to where the people are at, we gotta know what the game is. How do we communicate on their levels? How do we get our message about early detection? Why it's so important? And Doc, when we get them to your office, listen, I tell guys all the time, you spend more time with the intake person than the doctor. If the doctor come in there and give you 10 minutes, I reschedule, because this is so important to that. You just can't, the intake person get all your information and you sit there 30 minutes, and then when the doctor come, they give you 10 minutes. I tell guys reschedule, because those are so important. And when you're making a health decision, doctors, understand, I tell guys, don't do it right then. Listen to the info, go home and pray about it, do your research, talk to family members, talk to survivors, because that's the best way we can find the best treatment. As a survivor with 2 brothers older than me that had prostate cancer and enlarged prostate, and for the panel, my brothers, but one of them got diagnosed the same time I did, and we didn't tell each other. And all 3 of us got the same urologist, but through the privacy laws, he couldn't say, I'm treating your brother. So to answer your question, so I can start rambling, to answer your question, it would be, I would hope that this panel would come up with other ways to be able to reach the person that don't really go to the doctor, as Dr. Odetna say. We have to go where they at. We have to talk their language. And when I recruit somebody to come to you, you got to be able to understand when they coming out of scaredness. They coming out of not knowing, you hear cancer, I'm gonna die. I should have been dead 2 times, lung cancer and prostate cancer. But my mission is to be able to tell people that there's hope. Educate yourself, go to the website. I'm not a big fan of Facebook, Google, trying to Google stuff, because the doctors got the most important information. If you would just listen, and you can just break it down a little bit more, Doc, to where we can understand it, and leave your office, she know what she talking about. But you don't want to leave your office more confused going out than you came in. Thank you, Virgil.
Thank you, AJ. I think you touched on a few points that are important. First off, it's important that we understand our particular diagnosis. As we talked about, that your Gleason score can indicate different levels of aggressiveness, and that's your particular cancer. Now, again, who you talk to will determine how it's going to get treated. You go to a radiation oncologist, it's going to say, well, radiation is the best thing for you. You go to a medical oncologist, well, we have a variety of hormonal therapies that could work to help solve it. And probably for me, the best information I got and helped me to understand this thing was from a surgeon who eventually became the surgeon who took care of my cancer. He said, look, I'm a hammer. Everything looks like a nail. So you asking me for my opinion, I'm a surgeon. This is what I do. So I think it's important that you understand, first off, what is the option you want to take. Secondly, you want to decide, who do I want to have do it? And again, having, particularly prostate cancer, the skill of the doctor is paramount to the success of the procedure. Now, you want to have a doctor who understands the technicality of doing the procedure, who's done a lot of them, who does a lot of them, who's seen it and can do it. Again, the same doctor says, well, doc, with my cancer, what is the likelihood that we have the surgery, we're going to come out of this thing okay? He said, well, in my last 900 procedures, men with your same condition, they had like a 94% success rate of containing the disease. And I understood that, that I understood 900 procedures that this guy's done a whole hell of a lot of. He's some what's successful, what's not successful, 94%. Yeah, I'd take that to Vegas any day. So from that standpoint, you got to be able to do that to make your informed decision about how you want to do things and be able to make it appropriate in writing. I think probably I want to ask you, Dr. Dronka, as a physician, how do you measure success? How do you measure, that you've done the best for a patient? How do you determine that this has been a successful outcome for the treatment I've given them?
So, you started with a very important thing, saying that the treatment, the individualized treatment, this is a treatment for your particular cancer, your particular situation that takes into consideration more than that pathology report. It takes into consideration everything, your, other medical problems, your, physical fitness, your goals, your values, your family support. It's a huge decision. On top of that, you have multiple different options. You have surgery, you have radiation. You mentioned, all the different hormonal therapies. So I often, tell my patients this is a team sport. Treating this type of complex, medical problems. Cancer is a complex thing, and it doesn't exist in a void and exists in a patient. So we're very fortunate, for instance, at Mayo Clinic to have a multidisciplinary practice where I have colleagues in every specialty that are available with a phone call, that all are in the same medical record, and we all see the same patient through that multidisciplinary clinic. And it is a lot for the patient because now you have to take in everything I said, that is super confusing. Then you go to see a radiation doctor, then you go to see a surgeon. But I promise you, at some point, it's the same like medical school. The first 3 years, I had no idea what's happening. And then all of a sudden, it all came together beautifully. And I'm, on organ systems, and I was able to think through a clinical scenario. That's, I think, what a lot of patients express too. Once I have a chance to hear it from you, absorb it from the other person, listen to the other person, think about it. I agree with what you said, not making a decision right on the spot. I don't buy a car on the spot, not even like a second-hand car on the spot, right? You should not make a life-altering decision on the spot unless you know exactly, or you had all the information and you feel like you're making an informed decision for you and your family. So in general, once patients go and see all these physicians and get all the information, have a chance to talk to their family, choose friends or survivors. Almost every patient, I think, finds somebody that once they find the information, this is what the doctor told me. A lot of patients record me, and I'm perfectly fine with that. And I say, you can play, as many times as you want, and to your family and your friends, and review the information we shared, because it is a lot. And I think once they have a chance to do that, and they come and they know what they want to do, for me, that's the first success. That's the first, way when I realize, okay, I did my job, because that patient now knows where they are, what their cancer is like, what are the odds, what are the pros and cons of each approach that we take, and they are ready to make a decision. It's not an easy one. They'll be scared about it, but they are ready to make a decision. The second success is I have patients that I'm following for 15, so years, patients that I inherited from my mentors, and we're still following, patients that I correspond through by email, and, they are doing fantastically well, and they are mentoring other patients. And to me, that's a huge success, to have the long-term survivors, and to have, patients that are cured, even, patients with advanced disease. So I think, that's probably how we look at success on my side of the table. I wanted to just say a quick thing about what you mentioned about needing more education in the communities. What we started doing, we did patient education symposiums. We did a general one in Orlando, and year after year the attendance increased. We did one in multiple myeloma, and again it increased significantly. It is indeed people that are interested in their families, people who either have, a loved one with the disease or somebody in the family. But guess what? Once those people are educated, they will go out and educate other people. And they will act as their own, like a little expert, in the group. And I would rather them have the information from us and understand things from the medical community, and from vetted information rather than Google. and then go out and be our ambassadors. So what we're planning to do, we're doing a prostate cancer patient education symposium in January. And really, we're planning to do this for almost every cancer and to expand, this network and this ability to reach patients.
Well, I think that's a perfect entree for Dr. Odedna, because again, all of that things that we were talking about here in terms of education, intervention, awareness, and personal responsibility really fall into her areas of research and the kind of things that she's looking to bring to Mayo and to the state of Florida and to the United States and to the Caribbean and to Africa as well. So, Palaki, why don't you kind of sum it all up?
Absolutely. I think, so I want to sort of talk about my own research area, because what we call our research area in the scientific term is called community engagement research. And community engagement research is when we partner with the, consumer advocates, with prostate cancer survivors, with prostate cancer patients, to truly come up with the question. So it starts with, what questions should we be asking and how should we answer those questions? And when we answer those questions, what do we need to be able to develop that intervention that is tailored to those Black men? So this is what we've been doing for 3 decades now. And it has led to different things. So for example, it has led to developing video interventions that is personalized at each stage of the treatment. So we have a personalized video for person who wants to learn more about prevention, about screening, about the treatment, hearing from the Black men. I actually love, there's a project that was funded by Department of Defense that is called the Prostate Cancer Care and Survivorship, that Mr. Merriweather actually is one of the prime people who was part of that study and part of the interventions that we developed. And it really talked about all the prostate cancer care continuum. And the men were discussing what it was like them. And then we actually had the clinician come up and talk more about what you do within that particular thing. And I think it becomes very important. There are 2 ways that we can do things. There's that way of where we have to tailor the intervention to the men. And we have to do it based on the study that we have done in asking those questions. But another way that I think one of the things that we are now looking at is what is called the precision community health, where we actually want to be precise with the way that we educate within the community, which is what matters. We want to be able to use the evidence, we want to use the data, the geographical precision that we have within the community, so that we can say, we are going to this section of Health Zone 1, this zip code. And what we are going to do in this zip code is this particular education. We are going to tailor it to this community. But when we move from this zip code in Health Zone 1, Jacksonville, for those of you who are not Jacksonville natives, I'm talking about Jacksonville, we move to another zip code. This is the data that is driving. We are looking at the data, we are looking at the information that is provided, we are looking at the social determinants of health, we're looking at the information provided at the individual level. And this intervention is what we are going to be based on that. So with that, we are developing those interventions. Another thing that I think becomes very important for us that we should not shy away from, 2 things actually. I really want to talk about the idea of the significance of having prostate cancer advocates and patients and survivors partner with scientists. It is crucially important. I have seen, and I'm sure, Virgil, you can say this, I'm sure you can close your eyes, read a grant and say, wow, this grant, no patient survivor touched this grant. No consumer advocate look at this grant. Look at what they are proposing. It is madness, right? I think one of the things that we are striving for, and I know we are doing very greatly at Mayo, is to say, for every research project that we are going to embark on that is going to address disparities in our community, we are going to make sure that we are going to have somebody that is called a citizen scientist. And I really want to take the opportunity to say, and Mr. Merriweather can tell you, Mr. Merriweather, actually, if you don't mind me telling the story, Mr. Merriweather was part of a project, a Department of Defense project that we did. And one of the things that came out of the project was that the men said, this is great project, this is wonderful. We want to be involved in being able to disseminate that project, the result of that project. And then we said, this is great. So Mr. Merriweather was one of the leaders that actually created a group of the men across the state of Florida who were all prostate cancer survivors, who were all part of the study. But then you know what they said? They said, you know what? It is great, we want to partner with you, but we need to be trained. We need to be trained. So we put together, and Virgil was part of the leadership who did the cancer advocacy training program for us. So we put together this team that developed a prostate cancer advocacy handbook based on the work that Virgil and I have done all over the world pretty much. And we use that handbook to be able to conduct the training program. So again, we are moving from not only are we doing advocacy training, and I know Norrin Stephenson will be proud of me, this is a pet project. We are going to be doing citizen scientist project training at the beginning of the conference that we have that is coming up in November 11 to 14. We are actually going to be doing citizen scientist training program on November 11. So please, contact the Center for Health Equity and Community Engagement Research. If you are a prostate cancer advocate or a survivor and you want to be trained as a citizen scientist who can be a research team member for any of our research that is ongoing one. So I wanted to kind of say that. Another thing that I wanted to say, and I would give the rein up, it is so important, especially in the era of COVID-19, that we have to get with it with technology. We are all going to be stuck at home. And now we have the Delta variants. And now we have another variant that people are saying that, the vaccine might not even work. So how do we empower? How do we take care? How do we educate? How do we raise awareness when we all cannot see or touch each other or be in a room together? Yes, Zoom is great, but there are other technologies, and I know Dr. Dronka is one of the leaders in the technology in looking at telehealth. How can we treat you from home? She's one of the leaders in that area. But one of the things that we are doing within our research program is what artificial intelligence are we going to use to be able to reach and educate our men? And we are working with Mr. Merriweather on some of this artificial intelligence to be able to do this. So we really have to use the technology and the tools that we have to be able to get the message across as best as we can.
Well said, Falaki, and I think it is important. I think, the COVID to me has brought about, many concerns, but I think the overriding impact of COVID is going to hit our communities, particularly at a higher level of disparity. Obviously, a lot of the medical care that we would have expected to achieve with our doctors and our physicians are not happening because we can't get to the hospital. We can't get to the doctor. He can't see the patients. He can't reach out and touch them. But I think also we started looking at the issue of our children in our schools. And now the fact that, many of the children are at risk, possibly from COVID, and the intervention is that we know the kids are going to have to learn from home. Well, the reality is they don't learn from home. And I think as we see schools that have not had in-person learning in 6 months, and particularly within our minority communities and our minority schools, that's even more of an impact. We're having our futures getting left behind. The kids are not learning, they're not being able to be current with those schools, those communities that have a higher level of learning activities in artificial intelligence, greater access to computers and all the rest of it. So I think when we start looking at the future for our society, it's much greater than just healthcare alone. And what it says is that we need to be able to take a greater responsibility initially for our health, but let that be a motivation for us to take responsibility for our communities overall. So on that little bit of preaching, I'm looking here, I just answered some of the questions, and I think probably there are a couple of questions that we can just ask here. Falaki, and I guess also Dr. Dronka, how much does family history and genetics play in whether I'm at risk for prostate cancer?
I would say a lot and turn it back to Dr. Dronka to fully answer that.
Thank you. I was going to say exactly the same thing, a lot. I think we know now that, the risk of prostate cancer, really, if someone has a first degree relative with prostate cancer, it doubles. compared to the risk of the general population. If you have 2 or more relatives, it goes up exponentially. So the family history is very important. There is a caveat here. Family history meaning prostate cancer usually diagnosed in someone that is younger than 65. If someone has a first degree relative that developed prostate cancer in their 80s, it carries a significance, but potentially not, the same as someone is diagnosed at a younger age. And it's not only prostate cancer that we look at. We look at family history of breast cancer, ovarian cancer, pancreatic cancer, melanoma. Again, we look at patterns in the family, what relatives had what and what the degree, is there, familial, degree. And then we also look at the potential kind of a cancer inherited predisposition syndrome, where someone can have a predisposition for more than one cancer. BRCA or BRCA mutation, is one example that we all know that could potentially, affect or lead to breast cancer, ovarian cancer, in addition to prostate. Nowadays, with prostate cancer, we really refer all our patients who are willing to do so to have a medical genetics appointment and discuss their family history. And the medical geneticist will determine if this is significant enough to recommend testing for a particular inherited syndrome. I think the benefits of having a medical geneticist do that is one, they do run the insurance and make sure that your insurance cover for all this, but two, they are there to explain the results to you, what it means to you, but also what it means to your family, what it means to your daughters, to your sons, what it means in terms of screening, what age do they need to start screening for what particular, cancers that are more likely to appear. In addition, for prostate cancer, if you have a BRCA mutation or a related mutation in a DNA repair pathway, you actually can be a candidate for a novel treatment, which is a particular targeted therapy that we use nowadays for prostate cancer. So it's important to really understand everything about the patient, everything about again, their family history, genetics, test for potential predispositions, and then test the tumor for all the type of, changes that could be present in the tumor, in the DNA of the tumor. We look at other potential markers that can tell us if one is a candidate for immunotherapy. So there is a whole information that we learn from that may not necessarily all be applied upfront, but will inform our decision-making going forward and how we sequence the different therapies that we have available. And you and I, Mr. Simmons, were talking a little bit before this when I mentioned, in my view, cancer is a marathon, and you need to think about each segment of the race ahead of time. You can't just play it by ear. You need to think about it. You need to get all this information up front. You need to think about, A, B, C, D, E plans, so you can make the most out of the treatments that were there, and you can ensure that someone, really finishes and goes through the race.
I think the key thing too is that some of the most important genetic research should be done at home. For example, you should know which of your family members have had what diseases. Did your father or uncle or your brother have prostate cancer? Did your mother or aunt or grandmother have breast cancer? Because all of these are causative factors. We need to be able to talk among our families to understand who's had what, because again, whatever those genes are, we're passing them on and we're going to live with them. So we need to be able to start understanding, particularly among our folks, who we are. And I think the whole thing is that now genetic testing, folks like 23andMe, you can get a genetic test done that really gives a complete history genetically of who you are from your DNA. So I think it's a great start to be able to understand what you're all about, and then be able to take that, with the family, and then get the professional geneticists that Dr. Dronka talked about to be able to see what it really mean in terms of my risk of disease in general. And I think we have one other question. Lucky, this question is from a pathologist in Nigeria, Dr. Andiniji. And I think this is something that you need to really address. Start talking about the less moderately invested countries and nations, you know,
Yeah.
the risk that they have in terms of health awareness and health intervention and
Mhm.
ability to have and afford treatment.
Yeah, that. So I do know Dr. Adeniji is actually the director of pathology for a consortium in Africa. So that is kind of the dilemma that we really, really face. And it is really unfortunate. In fact, my very first panel that I participated on today was looking at the issue of radiotherapy in Africa and how do we really use that technology for diagnosis as well as for treatment. And the fact that it's so, I mean, it's almost non-existent in the majority of the countries. And it's unfortunate because it really goes back to how much is assigned for health for each of the countries in the LMICs, and there's no insurance and there's no funding and there's no money. And even when the non-governmental agencies or NGOs, when they want to do awareness, they can only do awareness, they can't do screening, because when they do screening and people are then diagnosed with prostate cancer, there's no way to treat them. So you can't leave them worse than where they are. So this is where it calls on international bodies that are really able to support and to help. And it sounds like a stretch, but it's not really a stretch. This is where it also calls on pharmaceutical companies, because pharma companies, even when they are supposed to be doing and they're supposed to have the civil, they're supposed to have those foundations that helps the community in the LMICs, they are not helping them. Only God knows where the money goes to, right? So it's really is a tough sell. But I would say one of the ways that we are trying to address this is because there's now a lot of collaborations, North-South collaborations in looking at understanding prostate cancer in LMICs. And one of the things that we now say is that collaboration, you have to use that tool of collaboration to be able to support the patients over there. So if we are collaborating with you, there has to be something that we in the US bring to the plate to be able to support those patients and to be able to bring awareness. So for example, when we had a conference in 2018, you were there, Virgil, in 2018 in Nigeria, we included, a lot of prostate cancer awareness symposium for the patients. We also did for the advocates, we did training program for the advocates. So every time there's that chance, we have to continue, but we also need to be able to call on people. And I have to say there are quite a couple of organizations that are looking at helping, like Movember. I want to give it up for the Movember Foundation. They are supporting the research. They are looking into how can we support the patients as well. So, we have to just keep pushing until we can get the right. But ultimately, the in-countries really need to be able to, the countries need to be able to provide, provide health for their citizens.
Like, one of the things that people want to know is that you have this upcoming program in November. Where can they get more information about it? What can they find out about it? How can they participate in it?
Yeah, absolutely. Thank you so much, Virgil. So we have this conference that we do every other year. It was actually supposed to be in Barcelona, where Virgil is, until COVID hit. So unfortunately, we couldn't go to Spain. So we are going to be holding it virtually November 11 through 14. The first day is devoted to patients, advocates, survivors. We are going to have a sort of educational section as well as a training program for citizen scientists on that day. And the easiest way to be able to get the information is to go to the Mayo Clinic, Florida Center for Health Equity and Community Engagement website. So we will be providing information about this. And if you actually got information about this webinar, believe me, you're going to get the information about the symposium. So we are going to be reaching and touching you about that symposium.
Well, I appreciate all of you being here and supporting me to make me look good, with all this thing, because it's your expertise that really is important. And it came across very, very directly and appropriately with our audience. With that, I want to thank everybody, our audience particularly, for listening in. And I would encourage all of you to take, one or 2 points that came out of our conversation today, take it back to your communities and, and make a difference. you start talking to folks and then getting folks motivated to be able to make things happen. So again, I appreciate everything all. And we have, oh, Paul, the slide on the survey. You just throw that up. I'd appreciate it.
I
We
wanted to
have-
say as well, thank you so much for having me, and it was such a pleasure to participate in this and to talk with you, and I look forward to future discussions in the community.
We enjoyed your presence, and we hope you keep the same passion you have for patients that we've seen today. But again, we have a survey we'd like you to complete, and it's on the screen. So again, it's a survey that'll just help us to do a better job. Complete the survey. Let us hear your input. Let us hear what we can do to help you help do a better job next time. So we appreciate everyone who's been part of this, and we look forward to seeing you at the next time. Thanks a lot.
Enjoyed it. Great program, everyone. Thanks, Virgil. You did it again.
I do what I can do.
All right. Thank you,
Thank you
Doc.
so much. Thank you. Bye, everybody.